to the cloud, and here we are. Good evening, everyone. Sean Pierce from Dental Pierce here. Welcome to is it a Tuesday? You lose track with a long weekend, don't you? Welcome to a Tuesday evening in February. Depending on where you are, it's either snowing like crazy or you're freezing your little buns off. So why not be here for a webinar, right? What else is there to do on a Canadian winter evening? As I said, my name is Sean Pierce. I'm the president and CEO of Dental Pierce, which is probably the largest, certainly one of the largest and oldest buying group for private practicing dentists in Canada. What we do is we work with a whole host of wonderful people that can help drive your business success on multiple fronts. We can make sure that the pricing that you get on dental supplies, sundries, and a variety of other services your businesses will need are going to be priced as if you were part of a DSO, but you get to keep your independence and run the practice the way that you want to. And if you need some help on driving things from the revenue end of things, we can also help with that either directly or with a whole host of networked people that we can introduce you to. Our goal is just to make sure that the practice of dentistry is what you want it to be. So I want to thank everyone for being here tonight and doing a great job coming on with your cameras turned off and your mics on mute. I know that some of you may wind up having some questions during the course of the presentation. If you can just send them via the chat function, we'll make sure that Kerry gets an opportunity to address as many of those questions at the end as is possible. And I think those of you that were on just for some of the banter that Kerry and I were having beforehand know that I am recording this session. So it will be made available. Some of you I may not know, and you may have registered through other means and by virtue of someone else, sending the connection. And if you do want to have access to the recorded version, by all means, send me an email. You can get a hold of me at Sean, S-H-A-W-N, at dentalpeers.ca. Dental Peers, all one word. So you send me an email, I'll send you the link. All right. I am very excited tonight because we have a really good friend of mine and an absolutely wonderful speaker and wonderful person to present to you. Some of you have probably seen her because she has quite the reputation as being a phenomenal speaker, educator, presenter, you name it. Her name is Kerry Lepicek. And she, believe it or not, you look at her and she's been a dental hygienist for almost 2 decades. And it doesn't show, but she does a great job in her career on multiple fronts because she still works part-time in a general and orthodontic practice, but at the same time, she works as a coach and clinical coaching manager with Vital and also with our other mutual friend, Kathleen Bacrossi at RDHU, where she works as a Q&A coach and presenter. Now, I've had the opportunity to see Kerry lecture on a number of occasions. I've been, count myself lucky on that front. And she's done a lot of that, both locally and internationally, because she's regarded as a trustworthy expert in topics such as oral biofilm, halitosis, and what we are going to be addressing tonight with respect to the oral systemic connection. And I can tell you that when I have questions about that, Kerry is a go-to person for me because I know that she uses her own educational background, her own research skills, and her own network of connections to make sure that she's got the current up-to-date research on that topic. So definitely the go-to person that we are fortunate to have with us tonight. She loves educating. She has a passion and a focus with respect to educating her clients in the dental profession on not just dental health, but overall health and wellness. She is, along with our friend that we mentioned, Kathleen Bacrossi, a cast member on RDH The View, or RDH View. The RDH View. Did I say that wrong?
Yep, no, the RDH View, I know, don't worry.
Okay, all right. And it is a featured podcast that appears regularly on Kathleen's channel, and Kerry also does a lot of work on having done several appearances with Dental Hygiene Quarterly webinars and a whole host of podcasts because she's just that in demand. I think you are going to be very pleased that you join us tonight because you are going to get a lot of wonderful practical information that transforms your practice, but more importantly, transforms the oral health of your patients, because that is Kerry's focus. So without further ado, I am going to turn it over to Kerry and let her drive this bus.
Well, that's a really nice introduction. Honestly, I am really happy to be here with all of you guys tonight. I think that this is a really amazing topic and one that sometimes we don't really dive enough into as far as the connection between oral health and systemic health. So today we're going to talk about sort of shifting our focus to close that gap. We're going to talk about ways that you can educate your patients, things to look for, red flags that could be standing there in front of you that will help you have this conversation with your patients. So a little bit about me. Sean did tell you I've got my wonderful ladies on the RDH View, which we do once a month shows of interviewing different people, offer free CE that way as well. I've got my lovely family who are my why behind my do. They kind of keep me going. They challenge me to always, challenge myself and step it up my game all the time. In my 18 years of hygiene, I've had the pleasure of working alongside my dad, which has been really amazing, honestly. He is sort of a forward thinker with everything and has helped me grow to where I am today. But every day when I'm in clinic, I'm just like probably all of you that are tuning in here. I feel like I'm a tooth fairy. I save teeth, I save lives. And the truth of it is, if we improve our assessment, if we improve our connection with our patients, together, we ultimately are saving lives. We're saving teeth and we're saving their whole body and systemic health. So I want you to take a look at this picture for a minute. What do you see? Because my husband and I see two different things. So take a look at it for a second. So when I first saw this picture, I saw an older lady and an older gentleman. But when my husband saw this picture, he saw the two gentlemen sitting there, one's playing the guitar, and he called it a lady standing in where I saw was the ear. And so a lot of times with the oral systemic connection or some of the red flags we're going to talk about today, sometimes they're hiding there in plain sight. We just didn't see it from that perspective. So it's a matter of shifting our focus, shifting our direction, kind of opening up our scope so we can really tune in and handle and help our clientele throughout everything. So in dentistry, I don't know about you, but sometimes I feel like I'm walking a tight line, like a tightrope, because I'm trying to make sure that my patients are happy, that my patients are healthy, that my patients are booking back, that I'm staying on time. It's overwhelming, all the things that we have to do in our day multiple times. It's like having 8 to 12 business meetings with our patients as we go through. But when we talk about periodontal therapy, we have to play chess. We've got to get checkmate. We've got to win every single time. But the truth of it is sometimes we don't win. Sometimes we're gambling. We're throwing the dice up and saying, I really hope I get all the matching pairs. I hope we get the score that we want. And this is where we're truly lacking. And so in dentistry, sometimes what we think is a great plan ends up being like a Jenga game. And if you've ever played Jenga, I love this game. It's about strategy and it's about luck, because you've got to pull out those bricks and you've got to hope that whole tower doesn't fall down. And the truth of it is, when I get to work with some offices with their perio program, sometimes it is like a Jenga block. They're doing okay until things start to disintegrate in front of them. And there are many things that you can do to help build this black up so you can get checkmate all the time with your patients. So dentistry years ago, dentistry today, what's changed our world is COVID. And sometimes I think there's some positive light that has come out of this. Awareness for our patients about what we need to do to keep them healthy and also to keep us healthy. And, what we used to do, how we used to look, what we used to, say to patients has to change as well. Our whole shift, our whole focus has to go from what we used to do back in, 1999 or 1998 or even 2019 to 2021. It has to be different. We have to see this new modification. And so, we have pivoted in dentistry, and so does our direction and our conversations with our patients. So how do you really shift yourself from just getting your patients healthy to truly, how do you shift your focus from cleaning teeth to getting people healthy? And this is a conversation, it's a philosophy of care. And it's about not just focusing on the procedures we do, but looking at the patient as a whole, looking at all of their risk factors, because these are all things that are going to impact what happens when you offer those interventions and those therapies. So, what are my goals for each one of my patients? Every time I see someone, these are the three pillars I talk about for my periodontal therapy and just my philosophy on looking after patients. First off, it has to be biofilm control. Now, remember, we don't see our patients' mouths every day. We don't get to brush them for them every day. So we have to educate them on what they need to do. Because if they can help control their biofilm, they're going to ultimately help all the results we get. It's also about education. So we have to find some sort of lever, some sort of motivation to educate our patients on or about so then they can make a shift and a change to improve their oral health, improve their systemic health. Maybe that education is about how they need to brush or how they need to clean. Or maybe the education is just about some information you've learned and you're sharing it with them. I find that is a really, really powerful tool I use with my patients is I'll say, hey, Mrs. Jones, on the weekend, I attended this course and it was fascinating. I didn't know all of this stuff about Alzheimer's, or I didn't know all of this stuff about colon cancer and how it relates to oral bacteria. It's really fascinating, some of the research that's coming out. The reason education is so important is it differentiates you from the average practice. So, this is something you can use to motivate them as well. And your patient, no matter what their diagnosis is, has to be motivated, has to be inspired to help make change. Because these are the three pillars that will make you and your team very, very successful. So, periodontal disease, we know about this, right? This is what we live and breathe. But the truth of it is that I think of periodontal disease as an inflammatory disease. It's not just around the teeth and gums, which is really where we spend most of our time focusing on. It's about a whole mouth biofilm concern. We know it doesn't generally hurt until they're starting to lose teeth. So that doesn't scream, oh my gosh, help me. And this is what makes it really hard for us sometimes to discuss and document and educate and get them to say yes to the therapies and interventions that we're suggesting. The other thing is there is such an impact on the oral systemic connection. It is all linked together. Sometimes the periodontal disease is progressing the systemic disease. Sometimes the systemic disease is progressing the periodontal disease, and they can go hand in hand. So we have to be aware of this connection and educate our clients. It's also transferred. So I don't know about you, but it is a conversation I will have with my patients. I will let them know that if their mouth is infected or inflamed and they have a partner, they can share that bacteria and share that concern. Same thing goes if they all of a sudden were very healthy and all of a sudden mouth is blowing up. They like to talk to me. They like to tell me things. So I'll ask them sometimes, did you get a new boyfriend? Did you get a new girlfriend? Maybe this is what's leading to some of your breakdown or some of your concern. It's chronic and it's persistent. And it's good for us because it means we always have business, but it's bad for the patient. It's really hard to disrupt some of this biofilm because it's so gooey, sticky together. It's like a 17-story building sometimes, and we need it to be like a single layer house so we can really control it and clean it and manage it for our patients and with our patients. Also, when I look for signs of disease, I'm looking for many things. I'm looking for signs of inflammation, bad breath, bad taste, bleeding, odors, all of those things, because it really is a combining factor of inflammation, bacteria, and biofilm. All of those things together lead to the progression of periodontal disease. So we know that there is a lot of research that's coming down the lines. I feel like every day there's something new that's coming out. And we know that oral systemic component is linked with heart disease, stroke, diabetes, pancreatic cancer, Alzheimer's, rheumatoid arthritis, preterm birth weight, life expectancy. All of these things are linked together in some way. And these are things that we should be looking for on the health history that should flag out and say, oh, you have a history of heart disease, you have a history of diabetes, you have Alzheimer's that runs in your family. Let's see what we can do to mitigate to reduce your risk. I never say I can eliminate their concern. I never say that I can eliminate their risk, but mitigate, reduce is really where we want to live and breathe and what we can truly do for our patients and our clients. So what on earth does oral systemic risk really mean? It means as a dental professional, we need to look at all of these factors and more, okay? It's about lifestyle for our patients and educating them about that, screening their lifestyle. We want to talk to them about inflammation, not only what we see in the mouth, but maybe throughout the body, okay? Nutrition. Nutrition is huge, and gut health. You have to be healthy from the inside out so then everything will heal. Maybe their bleeding gums are not necessarily related to bacteria. Maybe it's related to a deficiency in vitamin C. Maybe they have like a scurvy type situation. And so we really need to evaluate and educate, or if we can't do it, we refer them to some professionals that can help us with this. We don't have to be the master of everything. We just have to know who to refer to, who to bring into our circle, and how to help our patients and clients overall. Sleep and airway are so important for body health as well as body rejuvenation and everything else. We need to understand biofilm. We need to know how to measure it, how to record it, what to look for, and where to find it. It's a combination factor that we need to look at. How does the bite fit together? Does the shoebox lid fit the bottom of the box? If it's not fitting properly, well, that can lead to other concerns and breakdown for us. And what systemic diseases do they have? And what systemic disease do their family history have? It's a combination. So when I do my health history with my patients, if they say there's nothing on their health history, I always say, well, tell me about your family. Do you have a family history of diabetes? Do you have a family history of cardiovascular disease? It's a combination of things to understand risk. So when I see my patients, one of the very common conversations I have with them is I say, listen, I'm like a mechanic, okay? I can do engine jobs and full out transmission work, or we can do quarterly oil changes. What would you like us to do? Because sometimes they don't understand the significance of what we're selling. It sounds really expensive and it sounds really problematic, and they really want to have that oil change, that really small cost and quick appointment, but they don't understand what they're really saying yes to. So it's important that you use communication skills that are going to relate to it. So I'll say to them, listen, with your gum health, with your pockets, you've got stage 4 unstable periodontal disease right now. So we need to do 3 therapy appointments with you, and then we'll be able to just have regular routine oil changes. But if we leave it this situation, soon you're going to lose teeth, and we're probably going to have to refer you to see a specialist. Having these conversations makes a big difference with your family, because they are your patients and they become your family. It also can't just be in one single department. So it can't just be the dentist talking to the patient about this, and the hygienist and the assistant and the admin people do not understand it or aren't buying into it. It should be a whole team approach, because we're all intertwined. And I can tell you, I can educate my patients all the time. They'll go out and look to the front desk for reassurance. They'll look to the assistant or to the doctor for reassurance. This is something that really can help catapult your team, and you're really going to make a big difference in your patient's overall health. So periodontal disease and premature death, there was a very interesting study that came out of Sweden, and it looked at 1.2 million people. And what it was looking at is when you lost a molar and how you lost the molar. So you had to lose a molar by the age of 40 from periodontal disease. What they found is that women that lost a molar by age 40 died 36 years earlier, and men 31 years earlier. And so what we have to do is we have to look at that bacterial burden for that patient and think of the extent of the disease that they had. Chances are, if you look at some of your client base now, if you see a patient that's losing teeth by the age of 40, you know that they're unhealthy. You probably know that they have systemic diseases, either diagnosed or undiagnosed. Something else is going on. And the whole thing is, we really want to sort of handle these patients very aggressively and manage them really early, because we don't want them to have systemic concerns later on in life. So I really, really like the new AAP staging and grading. I found that once we started integrating into our practice, it was much easier for our team to be aligned. One of the things I really liked about it is it really brings up the point of missing teeth as one of the points. And so if you've lost a molar from periodontal disease, you're automatically on the right side of this table, right? You're in stage 3 or 4. And so you're a more advanced, more complex case, someone we really need to monitor. And I really like that they brought that in. Knowing the information from the Swedish study, it kind of resonated with me and was like, yeah, you're right. We need to be on high alert, and we need to ask our patients, why did they lose their teeth? How did they lose their teeth? Because up to a few years ago, I would see a missing tooth and I would say, oh, great. Would you like an implant? Would you like a bridge? How can we fill in that space? I didn't focus on the root cause of the problem and how they lost it. Grading. Grading is also a really great adjunct to use, especially with this whole oral systemic component. It brings in risk factors like diabetes and smoking. It brings in the phenotypes, the amount of deposits and biofilm load, and how your body responds to that. And bone loss. Well, maybe the bone loss progression isn't from the biofilm, maybe it's from the diabetes. Maybe it's from some other autoimmune disease that the patient is suffering from. And so we have to bring in all of these other risk factors when we're making our diagnostic statements and truly understand this interdental connection. So I was so excited when the AAP really came forward and was really truly recognizing diabetes and how it affects periodontal disease. So we know that with diabetes, if you have diabetes, you're an increased risk of progression of periodontal disease by 86%. But on the flip side of that, if you have treatment with periodontal disease can also have impact on the glycemic control. And so what we want to understand is that if you have controlled diabetes, you're going to have a very similar treatment outcome to those without diabetes. So we have to find that happy medium. When I'm talking to my clients with diabetes, I'll say to them, listen, it's really important we get your mouth healthy because then your body won't respond as much. Then we can really truly have a healthy you. Sometimes that means they need sort of multiple appointments. Maybe it's sextant or quadrant therapy. Maybe it's half mouth therapy. Maybe it's over-the-counter rinses or DNA sampling. It just depends on their case and all the other aspects that we're dealing with those patients. When you're screening patients, I have been lucky, I guess in some ways, maybe not so lucky, but I've had 3 patients in particular that I know of that I've said to them, listen, if you're bleeding like you are, if your tissues are responding like they are, and you promise me you're brushing and cleaning the way I've showed you, then there's something else going on. In all 3 cases, hadn't been to see their primary care physician for a very long time. They went in finally, and they came out. They all had the diabetes. And once their sugars and everything else were under control, their perio stabilized. It was so, so fascinating. So please be aware, look for these risk factors with your patients. Are they bleeding a lot? That seems excessive, that doesn't seem right. What's their healing like? Are they responding to your interventions and your therapies? Are they suffering from decay? Maybe that's the sugar in the curvicular fluid that's creating the problem. Or are they insulin resistant? What's their thirst like, their dry mouth, their urination? Is there frequent urination? Honestly, I'm shocked at some of the things I know about my patients. They feel like they sit down in my chair and it's like Pandora's box. Out comes all this information. Do they have vision problems or fatigue? These are good things to look at when we're looking at our client's health and we're trying to figure out why are they not healing. So the other thing we should be aware of is that any person, any woman who has had gestational diabetes is at an increased risk later in life for diabetes type 2, cholesterol, and high blood pressure. But they also are at risk of 66% increased risk of having cardiovascular disease. So it's not just that I had diabetes when I was pregnant and now I'm fine. Those patients in my mind are still at risk. So let's keep their periodontal status under control. Let's educate them about things as they go along to help reduce their concerns. So when you see a patient, you're doing your head and neck examination. If you see a lot of these little skin tags, what could they be related to? Because I've seen them in my patients. They don't have them. And over a period of time of working in the same practice with the same kind of clientele for 18 years, I'll see people develop these. Well, they're actually linked with diabetes. Interesting enough. So if you start to see something grow that wasn't there before, educate your patients. And if you see these and you see increased bleeding and you see increased bone level, have them have their sugars checked with their doctors. Maybe there is something that's happening there. What do these 2 men have in common? These 2 men in this picture, it's not easily able to see, I know, but they have something called Frank's sign. And Frank's sign was first associated with cardiovascular disease actually back in 1973. And it is associated with stroke and carotid intermedia thickness independent risk factor for cardiovascular disease. And it often will show up in men. So if you're a lady that's watching this and you've been wearing long earrings, I feel like my earlobes, every time I talk about this, I'm like, oh my gosh, am I going to have a heart attack? It's not as prevalent in women because we do have earrings that sort of hang down, but in particular with men, it can be a condition or a concern. So again, you're doing your head and neck examination. You're looking for signs that could lead to systemic disease issues for your clientele. So the other thing we want to look at is heart health. Okay, heart health and gum health go hand in hand. And so what we need to get across to our patients, you need a healthy mouth for a healthy heart. You need a healthy heart for a healthy mouth. They go hand in hand. So let's look at that a bit further. These two individuals, Dr. Bradley Bale and Dr. Amy Doneen, have done a phenomenal job bringing the dentist and the medical side together. They wrote an amazing book called Beat the Heart Attack Gene, and it really is an amazing educational tool that anybody can read. And it talks about lifestyle, it talks about diet, it talks about, medication, and how do you really reduce your risk, because it's about risk assessment. And for the dental professionals, what they really have pioneered is they will stand up and say high-risk periopathogens contribute to the progression of atherosclerosis. And they really are bringing this together. What they found in their practice, which was solely initially to treat people that have had heart attacks and strokes, is that they couldn't reduce the inflammation markers on their patients as well as they wanted to, controlling all things they could: lifestyle, diet, medication, and risk factors. And so what they start to look for is, where is this other inflammation coming from? And it's coming from the oral cavity. So what they have done, and people that follow their philosophy of care are starting to network and work with dental offices to truly not only get their heart health and their body healthy, but get their mouth healthy. And what they talk about is controlling particularly 5 high-risk periopathogens. We've got our AA, our PG, our Tenorilla, our T. denticola, and our fusiform nucleatum. These 5 key player bacteria, when you're reading a lot of the articles, you're going to see that these 5 key players are often there. And they're finding them in many, many systemic diseases. And so we need to get a better handle on if our patients have them and what the risk factors are for this. There's also a relationship between high blood pressure and periopathogens, and I found this article pretty fascinating when I read it a few years ago. And it looked only at 650 people, but what they were looking at was P. gingivalis, T. denticola, AA, and fusiform, T. forsythia. And what they found is that not always did the patients show signs of periodontal disease, but the patients with the highest oral bacteria often had the highest level of high blood pressure. So they kind of go hand in hand. So if we reduce the periopathogens, maybe we can also help to reduce the concerns and the stress on the heart and the blood pressure. So what if your patient's sitting in the chair and you start to notice these on their face? What are they, first off, and why would I be concerned? So I'm concerned because it's called xanthomia. And xanthomia is an independent predictor of a heart attack. Okay, and that is a really, really important sign. So we're checking our head and neck for our patients. We're looking for signs of diabetes. We're looking for signs of cardiovascular disease. We're looking for signs of xanthomia, because if you have this, you're at a 48% increased risk of having a heart attack. And so it usually is asymptomatic and usually bilateral. So again, you see these sorts of things that weren't there on Mrs. Jones. She comes in, you start to notice them. Again, have a conversation. Could you let your doctor know, I'm noticing that you're getting this sort of lipid layer buildup? Just make a call to your family doctor, let them know you notice them, and let me know what they say, okay? Fordyce granules. So I don't know about you, but when I was in school, these were WNL, within normal limits. I don't look at them that way anymore. I really don't, because they are a concern and they're linked with high cholesterol. So, this hyperlipidemia can be related to genetics for sure, and it can be a result of high lipid levels circulating in the blood, which is a concern for me. And so dentistry and healthcare professionals, when you see this, we should be having that conversation. And again, I see it, I'm concerned. I want you to go see your family doctor and let them know that you have this. Let them know that it wasn't there and now it's starting to develop. Okay, so if you're doing a new patient exam and you're snapping pictures, great option. Keep a picture of this, see how it grows, see if it changes, monitor it, and educate your patients about what you're doing and what you're looking for with your examinations. So the Big Bang Theory of Alzheimer's, I feel like there's so much research coming out now with Alzheimer's, and tonight we don't have time to get into all the nitty-gritty of it. But the truth of it is that there's a lot of links now, and there's some oral components that I want to sort of bring up. What they're looking at Alzheimer's now is a bacterial, a viral, and a candida infection that kind of all come in together to lead to the progression of Alzheimer's disease. In 2011, we started talking about spirochetes. And in 2019, we really started bringing in P. gingivalis, and now we're even bringing in Candida and a viral component of it in 2021. So with spirochete infections, really we have to remember that they're chronic, and these chronic infections cause a slow progression of dementia. There's often atrophy that happens, and there's a chronic inflammation that continually is fed that leads to the progression of the disease. Alzheimer's disease is now being referred to as a neurospiroketosis. And what they're finding is that on the brains of Alzheimer patients, they're finding 1 of 6 oral spirochetes when they die, which is pretty fascinating and sad all at the same time. And so we know that in order to have this infection, just like periodontal disease, it takes years and decades for it to develop. But we really kind of want to do our best to mitigate the oral pathogens, the risk concern, to try to help our clients long term. So when we think of what spirochete infections have been around for years, we've had syphilis for a long time. And if you have syphilis, then usually if you take an antibiotic, it helps to mitigate and manage the concern. Same thing with Lyme disease, right? Lyme disease came out, I feel like it came out about 10 years ago. I've had 2 family friends that have it. One is in remission, one was unable to kind of get into that remission state with her disease, but it's linked to spirochetes. Periodontal disease. Spirochetes are very much involved with generally the more aggressive forms of perio, not always, but definitely they are one of the key players. And Alzheimer's disease, they're starting to bring FN, Candida, and T. denticola all together as they're not necessarily saying causative effects, but they're seeing it as a link. They're noticing it there. They're just not sure how to mitigate it. Again, with periodontal disease, there are antibiotic type options. There's lasers to kill the bacteria. There's ways to kind of help combat it, to mitigate it. I'm really hoping in the future we can come up with a really great option for risk reducing of Alzheimer's, as well as different treatment strategies to help them. So with Alzheimer's, it's really important to understand risk factors for your patients because they don't always know these things. So sleeping can be a big factor, diet, depression, smoking, high blood pressure, pathogenic biofilm, which is our world, right? What their lifestyle's like. Are they exercising? Are they not? Gender, genetics, age. And interaction and learning new things are also part of it. Given COVID in the situation, I think we're going to see an increase in risk of Alzheimer's, an increase in diagnosis when we actually can get out, because there are a lot of people that are really segregated, living all on their own, barely talking to anybody, and we really need to find ways to interact with them. It can be, our opportunity, making sure that we interact and call our senior patients if they haven't been in, and just have that conversation to try to help them. Another risk factor that's dear to my heart is type 2 diabetes is a risk factor for dementia. And so we really, again, want to help manage and mitigate the diabetic patient the best that we can and educate them about all things diabetes to help reduce the risk of having dementia. If somebody has dementia, the dental profession, what we can do to help them really is focusing on I want to focus on them before they get dementia. So I want to focus on their pathogenic load and the aerosol production. I want to make sure that the client is assessed for inflammation and infection at every visit they come in. I want to know their numbers. I want to know their risk factors. I usually offer DNA and microbiological sampling to these sorts of clients. I want to really help them control and understand that oral systemic component and their health history concerns. If they have active disease, I want to treat as early as we can, and that can be also with gingivitis. I don't like gingivitis. I want every gingivitis patient to be healthy. That is our goal. Why am I waiting until they lose bone and they become a stage and a grade before I get excited? It's a long-term effect of having these pathogens in your mouth that's going to create the problem. We also want to talk to the patients about the importance of sleep and healthy diet. This is all the things that are in our scope of practice. And if you don't think that you're able to do one of these, definitely bring someone else into your circle for collaboration. When you're talking to your medical doctors, when you're in for an appointment or you've got them in your chair as an appointment, encourage them to make sure that they refer back to their dental professional. If they have a family history, if they've got diabetes, if they've got Alzheimer's, make sure they come in to see us. We want to help mitigate them. We want to help to make sure that they have a healthy lifestyle, a healthy diet. We also want to make sure that if there's a concern as well, maybe suggesting a sleep test might be helpful as well. So if someone presents with two of the following, what might they have? And you probably have already guessed it, sleep apnea, right? And so we should be screening for sleep apnea because it has such a catastrophic effect on the whole human body, from cardiovascular disease to dementia to, just regenerating. We need to make sure that patients are sleeping and have enough oxygen, that they're not deprived of it, so that for them they can actually get healthy. So it really, really is important to understand some of the risk factors for sleep apnea and to make sure that you're aware of these things. So you may not do molar root canals, but you screen for them. So why is sleep different? And that is one of the biggest things I find is people will say, well, I don't know how to make the appliances and I don't know about this. But that doesn't mean you can't screen and suggest they go and have a sleep test done or go see someone that is making those specific appliances. So in Toronto, where I live and work, there are some specialists around that we will refer to go and get those appliances made, or take a course, do some continuing ed on it, and expand your practice to help your patients, because we really should truly be screening for it, because sleep deprivation, lack of oxygen is a huge impact to your overall health and body. So sleep is really important. We used to, on average, sleep 8 hours a day. I don't know about you, but I don't sleep that much, unfortunately. I think my average is now sort of 6.5 to 7. I am really, truly trying to make sure I get those target numbers all the time. And that when we sleep, it helps us repair our body. We need the REM sleep and we need the non-REM sleep. So remember, with REM sleep, it's really important because it stimulates your brain and the part of the brain that actually promotes learning, okay? And REM sleep is really important because it reduces your heart rate and reduces your blood pressure. So we need to sleep long enough to get enough REM sleep as well as the non-REM sleep, okay? Also, if we don't sleep enough, we're at a higher risk of Alzheimer's, and we don't want that. And we should be spending about 1/3 of our life sleeping in general. So what we need to focus with our patients and for ourselves on is the continuity, the duration, and the quality of our sleep. We should be on a system. We should be on, I think back to when my children were little, it was like they got up like clockwork. Literally, they were 6 o'clock in the morning risers. And by 7 o'clock, they were out and in bed. And that was their system. That was their way their body was trained. It's not good for our body to get up Monday through Friday at 6 o'clock and on weekends to stay up to 2 in the morning and get up at 10. It doesn't help your body rest and sleep. It creates stress. So having that consistency and making sure we get the duration of sleep will improve your life and everything else. Bowel cancer is something else that's really, I find fascinating, some of the new literature that's coming out, and they're really linking bowel cancer to oral biofilm and bacteria, and they're finding it generally in all colorectal cancers. So if someone has a family history of colon cancer and they have high pathogenic bacteria load, really educating them about low fiber diets definitely increase the fusiform in the gut, but a high fiber diet reduces that. As well as using systemic antibiotics in diet can definitely change the gut biome and increase the risk of colon cancer. And that's a matter of using the systemic antibiotics on a regular basis. We do need to use them sometimes, but just not as our go-to every 3 months would be the ideal situation. So if you haven't heard me talk before, I am so passionate about indices because indices can really give us some additional options and some additional ways to educate our patients, and also to tell us that something's not right with their health and maybe it's linked to something else that's going on in their health history. So Periodontal charting, honestly, I feel like periodontal charting is not done enough. It's not done complete in most practices. And so with periodontal charting, we want to make sure we do the 6-site bleeding on probing. You want to make sure you're doing your furcations, your mobilities, you're doing your furcations, your mobilities, that you are recording bleeding on probing. It really, really is vital. But also what's vital is taking that information and creating a treatment plan, coming up with a plan for attack for that client, figuring out what you're going to do, what treatment and therapies are you going to offer them to help them get healthy. The nice thing is that some of the softwares now actually have a summary tab that will total it all up. So when I'm talking to my patients, it's not just about a 5 or a 7 millimeter pocket. I also need to know what's actively happening, because that tells me risk. They can have a 5 millimeter pocket and have it be stable for a long time with no biofilm and no bleeding. But if they have a bunch of inflammation and a bunch of bleeding in their mouth, that 5, I am paranoid that it's going to all of a sudden disintegrate on me. So have a plan, have a strategy. So if my clients come in and they have 30 plus bleeding points, it's the size of a quarter sore on their mouth, I'm suggesting DNA sampling. I may be suggesting antibiotic rinses to help heal them. You come up with the plan, you come up with the protocols, but make sure that this is here, because this will help you understand risk for your patients. Given COVID too, it's really hard sometimes to get someone to come in to chart with you, given the situation, if you're doing aerosols or non-aerosol. So maybe invest in a headset, maybe invest in some of the technology out there that does smart charting to make it easier for you to get this data so you can then understand clients' risk. So another big thing that I really love is interproximal brushes. I find that this papillary bleeding score is a game changer for me and a game changer for many practices. And I'm excited that there are a lot more speakers out there talking about this, because, you know, how many times have we seen someone and we probe them and there's been little bleeding, yet we get in there with our, scalers, or you place your wedge and it bleeds like crazy. And you're saying, well, it didn't look that bad. What happened? Did I traumatize the tissue, or was there disease there that wasn't as evident? The new AAP guidelines talk a lot about indices, and this is one of the ones that they really mentioned. And I truly find it so fascinating. Take an interdental brush like a soft pick, a proxy brush, something, and just go in between your teeth before you start to clean. And if it bleeds like this, guess what patients say? Ooh, how do I fix it? And record it, because this can be maybe a sign. This is what I did with my diabetic patients. And I was like, listen, if I rubbed your hand and it bled like this, you'd be concerned. I should be able to rub the skin around and in between your teeth and not have a problem. So this is a really great screening tool to understand healthy versus diseased. So it brings me up to the point again of flossing versus interdental brushes. I'm not anti-floss, but I can tell you it's not usually my go-to for every patient. When you look at the picture on the top right-hand side, you can see how the floss kind of comes around the tooth like this, and it leaves a big concavity area. I feel like there was a preposition paper that was released from the Clinical Journal of Clinical Periodontology many years ago now, in 2015, and it talked about how interdental brushes really should be used for sites of gingival inflammation. If they're healthy, floss all you want, but if there's disease, we should be using something different. Okay, and the reason we should is because cleaning with the brushes is like cleaning under the fridge and stove. You can't sometimes just sweep it away with floss. You need to actually rub it. And sometimes your rubbing actually needs to use chemicals or a laser or an over-the-counter rinse or an antibiotic to help scrub away, to clean off all those little particles. So when I'm talking to my patients and I show them that bleeding and I say, listen, I'm concerned, you've got cardiovascular disease, your diabetes is not controlled. Let's control this bacteria between your teeth. Use these little brushes, get them in there. 3 days it's going to squeak and you're going to make a big difference. So, let's see how we can do. Let's have you back to evaluate. Let's make sure your mouth gets healthy. This is how we have to position, bring in the oral systemic component to the clinical records that we see to help people get healthy. So I don't know about you, but I think everybody has an experience with Lego, okay? I recently have moved and we had this massive box of Lego, and I said to my husband, don't worry, I'll pack the garage. I put the box of Lego on the very top. Did it not fall over and go everywhere? And I'm trying to clean it up and I'm trying to clean up and it just feels like they just scattered, okay? And you can clean them up if you can see them. But what if I put a whole bunch of Lego in the room and I put a blindfold on and you'd miss some, you couldn't pick it all up? Biofilm is kind of like that. If patients could see all of the dirt, all of the Lego on the floor, they would be more likely to be able to pick it up. But when it's hiding and it's invisible, they miss it. And that's why this picture is a really true representation of what happens to our patients. They come in, we can see the biofilm on the left. They can't see the biofilm. And so when you use things like a disclosing solution, it highlights the area. And it's about risk assessment. If somebody has a family history, if someone has diabetes, if someone is trying to get pregnant, I want their mouth to be healthy to reduce their risk of spontaneous abortion or having complications due to diabetes in pregnancy. So we want to make sure we educate them, show them the biofilm, because they have their mouth for 4 hours a year. We have their mouth for 4 hours a year. They have their mouth for 8,000. And it's what we do in that 4 hours that's going to motivate them to help control the oral systemic component with them. Because bleeding gums are not normal and have to be taken very seriously. So we should be screening for them. And that includes using microbiological analysis. And so this is a matter of, using the oral systemic component, using microbiology to give us a degree and the risk of infection. Also, it can tell you the type and the location of the disease. And so this is a great way to figure out, are people at risk and what is their bacterial pathogenic load like? Who can you sample? Really, the list is endless, but I focus on generally colorful medical history. Periodontal stages sort of 2, 3, and 4 are generally my go-to. If they have a severe amount of risk factors is another concern and reason that I really want to sample those patients. Halitosis concerns and infected implants. Those are generally my top 5 go-to patients. When you get your report back, it's actually going to outline the type of pathogens that are there. I do work with Oravital, and so this is the report of the company that I do work with and the one that I use. There are 2 other companies that are out there that I know of that do a very similar report. Each company has a different level and type of bacteria that they use. So ours checks for P. gingivalis, T. denticola, Tannerilla, AA, fusiform nucleatum, Peptococcus micros, Candida, and strep. So it's kind of a good array of pathogens. Anything below that yellow line is considered normal. Between the yellow and the red is considered infection and monitor. And it's considered monitor. Anything above the red line is considered an infection. We also provide a list that shows if you have P. gingivalis, why might you be concerned? What bacteria, what conditions is that associated with? Because we know PG is linked with heart attacks and strokes. And we know that FN is linked with colon cancer and bad breath. And so this really helps you with that conversation, tying it together for your patients to show the need. This was an interesting case of a gentleman that we saw, and I thought back to that study where we talked about the losing the molar by the age of 40. So this gentleman was only 30 years old. He hadn't been the dentist in over 10 years. I think it had to be since he was honestly a child, because he came in and he had we couldn't probe him because he was so uncomfortable, and I couldn't see anything because he had 100% bleeding points. Everywhere I touched bled, okay? We found out from further diagnosis that his father had a heart attack at age 53. He did survive, and he also had type 2 diabetes at that point. So this patient, before we would treat him, we actually sent him off to see his family physician to get clearance, so then we could look after him. But this is really an interesting case because he ended up needing 7 to 9 teeth removed from periodontal disease. So this patient falls into that stage 4 category at age 30. This is a concern, and look at the amount of pathogens that are there. There are tons of pathogens that are present, well above those black lines which show threshold. This is an interesting case because this was a patient I saw, and she was 37 years old, but she's pregnant. And her main concern to come and see us was bleeding gums with on her pillow. So I found this report interesting because there wasn't a lot of pathogens, but her body responded severely to that low level of pathogenic bacteria. So sometimes it's not the amount of bacteria, it's how your body responds to that. And so this is where I find quite a difference in reports when I look at the family history and the bacteria that are present. So you can screen for this. It's very easy to do, and it's so simple and very motivational for your patients as well. So you can pull out the sliver in your hand and there's no long-term effect on your hand. However, if you pull out a tooth from periodontal disease, your body's still at risk until you manage the problem, which is the bacteria. And that leads us to a conversation about bacteria in general. So bacteria, I think of as like a skyscraper, okay? It's like a CN Tower building, super tall, very dense, got lots of networks and everything through it, that you can't always just chop it down after one go, or scaling and root planing may not do that to mitigate it. Maybe we need to use and look at other alternatives and other options. And so I feel like gingivitis is honestly the canary in the coal mine. We often take too much of a casual approach, and then we wait till they become a stage 1, 2, 3, or 4, and then we get excited. We have to look at our protocols. We've got to mitigate gingivitis as early as it can before it progresses that way. And we need to evaluate our results. So what have we done with our assessment? We've got all this information looking at their health history, the links between oral pathogens, and now we want to come up with treatment options. So your options can be looking at systemic pills or antibiotic rinses when you have a more severe case of halitosis or periodontal disease. And sometimes in some situations, also I'll utilize it with gingivitis. So with the antibiotic rinses, the ones that I use from Orovital are a colloidal antibiotic. It's an antibiotic antifungal rinse. The nice thing is it's half the dose of a systemic pill, directly applied to the tongue, the throat, and the oral environment. So it gets in between the teeth and clears the whole oral environment. Most of the time we think of antibiotics in the systemic form, and most people don't like to take them. Many times there's interaction with other medications, people forget to take it, and many women will end up with yeast infections. So it's not always our first line of defense. The reason that these rinses work, I always get that question, is because it's a particulate solution that gets, those particles in the solution get caught in the sulcus, go through the whole oral environment and help to cleanse the bacteria and reduce the load. With utilizing these medications, what you're going to see is changes in pocket depths and bleeding points and control and management of halitosis. I see this all the time, but it's a whole system that we talk about biofilm, reviewing their health history, understanding risk, reviewing interproximal cleaning, and using this as an additional adjunct after you've done your DNA test to evaluate the pathogens that are there. There also are localized treatment options, which we really should be evaluating. Maybe you've got a laser in your practice. Why are you not using it? You should be pulling it out, disinfecting, irrigating, utilizing it to its fullest. You can utilize antibiotic localized areas into the pocket. You can do perioprotectorates, which gives you gel that you wear in to help clear the oral environment. It's really important when we see hot spots that we help to control it for our patients. There also are different rinses. And so what I encourage you to do is to look at the chemistry in your mouthwashes of what you're recommending and see, does it fit their disease? Am I recommending a fluoride for something for perio, or am I recommending something that's better for perio when they've got caries? So look at the chemistry, see what works better for your patients, and evaluate it that way. Implants are really important. I make sure that my patients understand who's responsible for the implant health, and that's them. Remember, they have their mouth longer than we do. But my responsibility is we've got to make sure we probe and check the sulcus for inflammation, bleeding, and biofilm every visit, every time. Take regular radiographs as prescribed by the DDS or the dentist. And if I see inflammation, I want to look at hot spots. Do they need laser? Do they need cream? Do they need an antibiotic or a DNA analysis to evaluate? Reevaluations are something that are totally underutilized. Your medical doctor wouldn't give you a statin and then never check you again for 9 months or 12 months. They'd have you back to evaluate. So what are your protocols? How do you evaluate that? And that's a big thing with the new AAP guidelines, is evaluating our results. Are people getting healthier? Have you shifted your focus so that for then they understand what they need to do? And what is your frequency? Figure out this plan and have it intact for your whole team approach with this systemic component. The reason it's really important is that we are trying to reduce bacteremias, and that people will test positive with bacteremia even 30 minutes after the procedure. And again, the bacteria they were finding was PG, FN, TD, and AA. So it's a combination of all these bacteria. And the thing is with bacteremias, it doesn't just happen in the office, it happens at home. Think of those interdental brushes, or people are brushing their teeth and the gums are bleeding. That's the same exposure. So we have to educate them to reduce their risk of having heart attacks and strokes and Alzheimer's and pancreatic cancer and all these other things. We've got to get the gums healthy to reduce their risk. So what are my goals for my patients? So my goals haven't changed for a very long time. I've added in a few with regards to stability and remission with the AAP classifications, but I want every patient of mine to have less than 10 bleeding on probing. I want no bleeding when I use that interdental brush like a soft pick. I want no to little biofilm when I disclose them. Pockets 4 millimeters or less. Wouldn't that be amazing? No breath odor, no bad taste. And I want them to move into the maintenance phase versus the constant active periotherapy that we need to use. These are my goals, and it's a matter of incrementally going up the ladder with the patient over a period of time. It doesn't happen overnight, but kind of have your protocols in place so then you can help your patients and help your team. We need to halt the progression of perio, and this is where we need to bring in things like DNA testing, talking to them and understanding what their A1C levels are, what their CRP levels are. There's genetic tests out there too that look for interleukin, and you can see if they're predisposed to periodontal disease. Also, we need to look at our therapy options. Do we need to do more non-surgical periotherapy? Do we need to look at using antibiotic rinses or pills to help halt the disease and manage it with the patient? What local treatments are you doing? What mouthwashes and chemistry in those mouthwashes are you recommending? And how are you motivating and collaborating and educating your patients? These are the keys. So in order to expand your assessment to help your clients overall, look at these additional tools. There's got to be something on this list that you can do to expand and help your patients. Maybe it is the looking at family history, not just their health history. Maybe it's adding in things like risk factors when you're doing your risk assessment in your head and neck. You're looking for those diabetes signs, or looking for the cardiovascular signs or the lipid level concerns. Improve your indices to see if disease is happening earlier and to help mitigate that. Use disclosing, use your cameras, do your sampling if you want to add that to your protocols. So when we look at this, before tonight, you would really generally just see periodontal disease, you'd see calculus, biofilm. But now I hope I've expanded your thoughts to look at this more as a concern for heart attack, a potential for diabetes, need for biofilm, need for microbiological testing. And we need to stage and grade the disease and evaluate our results to make sure that we've mitigated their risk, which is periodontal disease. It doesn't happen overnight. We need an overall approach for this. And so it's a matter of focusing on those high-risk periopathogens, reviewing the medical and dental history, using their periodontal condition. So looking at the amount of biofilm with disclosing, looking at their periodontal charting, make sure you do a full and complete charting. Look at adding the papillary bleeding score, review biofilm control with every patient. Use your bacterial testing or add that to your protocols. Get your maintenance visits based on their stage and grade, and also bring in that professional collaboration. Over time, you will kind of make your way up the staircase and you'll make it to the top and be a really exceptional practice from adding 1 or 2 of these things as you go along the process. In dentistry, we make a huge difference. Honestly, we go the extra mile. People love it. People feel comfortable with it. And so I want you to look at your protocols. I want you to see how this all starts to fit together so you can really hit the target and nail it on the head and reduce risk, because that is the goal for everything that we're doing. That is where we want to be. Because if I do my job right, my clients are never going to feel it. So just do the right thing. And so I'd like to leave you with some additional resources, because this is just a short summary of a lot of the information I have kind of to share with you. And so these are some awesome books that I have read that I think that is well worth exploring and kind of furthering your knowledge with that way. Check out the OraVital website. We've got lots of free CE there that talk about the oral systemic connection in various ways from various presenters that way. And RDHU and the DHQ have got some really great speakers, courses that we offer as well that are linked into this section if it's something you want to continue your learning with. So I'm just a little bit passionate about healthy teeth. I'm responsible for oral health of my clients. The work I do makes a difference, and I am a dental hygienist. So I'm really proud to be here. And Sean, I would like to thank you and the Dental Peers group for having me tonight to share this sort of passion of mine and to and to, try to hopefully inspire some of your members and some of the people that have joined us. So thank you.
Well, wow. I mean, thanks so much, Kerry. I'm speechless at this point in time. I mean, I can recall, I've had the good fortune. We've been friends for probably more years now than we were both wanting to count.
Yeah, we're not going to go there, okay, Sean? We're not. We've kind of grown up together. We'll say that.
And, I mean, I remember being wowed by you
Mhm.
before,
Yes.
going back going back to some of those earlier days, and nothing's changed. I mean, the
Thank
information
you.
is phenomenal. The passion, I mean, the feedback we're getting is just incredible. There's just so much great information that you are able to impart, and I know it can probably seem a little bit overwhelming. And I don't know if anyone has any questions. Feel free to send them on the chat function. We have a couple of minutes. I know it's 8 o'clock. We don't want to keep everyone too long because it gets late into the evening. But if there are a couple of questions, by all means, there's an opportunity to throw a couple Kerry's way. But I mean, I look at it and I think it's inspiring on the one hand, probably to hear all this information and the power that we have in the dental community to be able to make a difference for patients that we don't necessarily stop to think of every day in our typical practice. At the
No.
same time, I can think that there's probably a lot of people that are feeling a little bit overwhelmed and intimidated as to how do I incorporate some of this into what I'm doing to be able to actually educate patients on this. And how do you address that when you get that question? I think you kind of touched a little bit at the end of your presentation. Do it in little bite-sized chunks.
It
But
really has to be bite-sized chunks and choosing one small change. We have changed so much in dentistry with COVID. We've had to pivot 110%, and a lot of us still are unsure when we go in and what patients are going to ask. But choosing one small thing to incrementally change your practice. So if you are passionate and you want to say, okay, the diabetes patients, those are the ones we're going to focus on the most when we're screening them. Let's make sure we select those particular patients with health history. Choose something you're comfortable with, because you might choose diabetes and someone else might say, no, it's cardiovascular disease for me. Find something you're passionate about and just focus on that. Try one or two people a day to educate them, to bring in this link to show them that you care and why you're different. And that's the easiest way to do it. You can't change your protocols overnight. And that's why I try to lay it out a little bit for you with the different options you have. And some of them you may be doing and some of them you may not. So just do it in bite-sized pieces, and incrementally you will get to where you want to be.
and one of the things I was thinking as I was listening to your presentation with respect to that is, obviously this is not something you address with every patient because the patients are not all going to report with some of the conditions that you outline. So you don't necessarily set aside time up front for conditions that you haven't seen because maybe you're just not familiar with what's going on. And even if it's an existing patient that you've had for a while, that we know health changes sometimes, and we've got them in for our typical appointment, and we're looking at then we see signs and we're thinking, okay, I have to do a little bit more based on the bite-sized chunk I've chosen. Do you prefer to do it, set up another follow-up appointment with the patient? Would you prefer to do that in person? Would you maybe start thinking in terms of a teledentistry platform as we're embracing new technologies as a result of COVID? What's sort of your comfort level in terms of how you look at that?
That's a really good question. So I am very good, and I've learned to be very good on my initial sort of 15 minutes in that appointment when I'm evaluating their health history and I see things just don't add up. I make a decision very quickly then about either having them back for a reevaluation, which would be a second appointment, or let's say splitting their cleaning up into 2 appointments. Or I will say, listen, I'm going to call you and I'm going to follow up because I've done quite a bit of teledentistry now, because it's really hard for us, and the cost of having them come in is so high that we have done a lot of teledentistry, and I've checked in and said, listen, has this improved? What are you noticing a difference with? Let's do an evaluation this way. And people can take pictures of their mouth and email them to us, and we can see it that way. So we can really track how they've truly improved or not. So I think embracing the Zoom connections, embracing whatever connection you feel comfortable communicating with your patients, but it really has made a big difference for sure.
I mean, that was just an easy pop into my mind because I know a lot of dentists are kind of looking at seeing all these promotional pieces
Mhm.
coming up for teledentistry platforms, and they're thinking, is it something I'd really use? And I'm listening to this and I'm thinking, this is that ideal time because, as you said, if this is a patient coming in now and it's been an unanticipated situation, and I know I'm going to want to address it, and I'm not going to have time in the appointment that I've set aside to fully explore the options in a way that is going to convey compassion and concern without conveying fear.
Yes. Yes. As you will say, you don't want to scare your patient, you want to care. And so if you see that deer in the headlights, as I
Yep.
use you all the time, that deer in the headlights, it's like, I promise you, I wasn't trying to scare you. I was trying to show you I cared. And one way that I find really helpful to get people to understand why I'm concerned, I'll say to them, listen, think of your car and taking it to a car wash. You've got three options. You've got a touchless, you've got the exterior, and you have a full detail. The problem is you're asking me to do a cleaning and I'm only able to do a touchless. But what you need is that detail. That's not going to be done, and I can't get it all done today. If you're not ready to go ahead with that sort of care, I understand. Let's do what we can today and we'll talk more about it the next time. And sometimes, just like talking about a crown, people need one or two conversations before they're ready to accept it or move forward. So it doesn't mean that you failed. Just try a different way of presenting the care. And that's why the mechanic conversation, the car wash conversation are very my go-to kind of analogies that seem to resonate with a lot of people.
It reminds me of listening to Dr. Paul Homily speaking in
Yeah.
terms of case presentation, because it's that idea that, as you said, you don't look at it as a sign that you failed because the patient didn't accept it right there in that first appointment. If you've created a connection
Mhm.
and let that patient understand, this is what I'm concerned about,
Mhm.
but my concern's not going to stop the minute you walk out the door. I will remain concerned for you,
Mhm.
and I'm available, and we can discuss it when you're ready.
Yeah.
I think that's a big aspect of creating that connection, that bond of trust.
And I think another way that I'll approach situations like that when I really know that they should do something, sometimes I'll say to them, especially with COVID, listen, it sounds like you've had a lot on your plate. Are you at a spot where you're ready to look after you? Or are you just being here because you're trying to do the best you can? And that way, then they're open to say, you know what, Kerry, I don't even have a moment to myself. This hour with you is my free time. So I'm not interested and I'm not open to it now. And by asking it that way, they're not feeling bad. And then eventually they say, okay, I'm ready. And I say, when you're ready, you let me know and we will make sure we reduce these. But I'm proud of you for coming in. Thank you for sharing your time with me today. Let's do what we can.
And I love that because you're providing recognition. The
Mhm.
patient is there. I mean, this is a even independent of a pandemic, life is a busy endeavor, right? I
Yep.
mean, we're always going crazy, and this is just added something new to it. So to be able to find a way to make a patient feel good about themselves
Mhm.
for doing what they can, even if you know that I'd really like to see you do more,
Yeah. Yep.
but there's times that you have to recognize you're just not going to win that discussion in the moment, and that sometimes it's the proverbial being in it for the marathon as opposed to being in it for the sprint.
Yep, exactly. And if they have that trust and connection, they are more likely to be open to it at a period of time. And those three lines have really been some of the best. I've got the best results with them and the best connection. And patients, if you provide service this way and they understand that you're looking at it differently, people don't cancel their appointments. They want to keep their appointments. They know that you're going the extra mile. They know you're different than the $99 cleanings down the street or, the free new patient exam and whitening. They know that. And so this is a great way to differentiate yourself and your team. And it's refreshing. And for us, if you could practice in an area where you're educating patients, it's exciting. You get to share your knowledge and your excitement, your passion. And if you can get them healthy at the same time, let me tell you, my risk of going to work is mitigated. I don't have a huge concern in dealing with perio disease all day long of active. People are healthy because they understand and we're in it to win it together.
And I mean, I listen to what you say there, and I'm thinking, those of you watching, whether you're watching live right now or where you're catching this on the video afterwards, that's just part of the coaching that Kerry can provide for you. It's not just about the clinical aspect and the great information and knowledge that Kerry has from the scientific side of things that she can share. It's this ability to be able to take that science that, let's face it, I mean, the average patient isn't going to have the full scientific background to understand, and bring it to a level so that they can understand it and coach them along so that everybody feels comfortable in the discussions that have to be had in order to address these conditions the right way. So Kerry, if anyone needed to reach out to you, let's give them one final reminder. What's the best way that they can contact you?
Okay, the best way to contact me is K, and then I'll spell my last name, Lepicek at gmail.com.
Can you, I think, oh, are you there?
Oh, did I
Yeah,
pause?
I think you might have froze. Can you just, yeah, it froze just right at the end there, just before you spelled your name and then at something.com.
Okay, so Klepicek at gmail.com.
Excellent. We got it in. The joys of technology, right?
I know, exactly. Freeze. Well,
Well,
thank you very much, Sean. It's been a pleasure. And for everyone that's joined us and watching later, I hope you've enjoyed it. It's been a lot of fun to spend my Tuesday night with you guys.
well, Kerry, it was, as always, it was excellent. And I really appreciate your taking time out of your busy schedule, as I know you're getting set for the big move, and to be here with us, and wishing you best of luck on the move, and look forward to seeing you someday when we can get together live again.
Exactly. Thank you very much. Bye, everyone.
Okay, everyone, thanks for joining us, and we'll see you in March. I don't have a date yet, but I've got things lined up. It's just I'm dealing with a financial planner, and they're really busy right now. So pinning them down is kind of a hard thing to do. So look for some information on when we have our next webinar. It will be coming to you probably mid to late March. All right, everyone, take care.
Bye.